This is the Psychedelic Medicine Podcast.
Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm Dr. Lynn Marie Morsky, your guide on this journey, and this week we're going to be discussing the potential of non-dissociative ketamine with Dr. Hans Eriksson. Dr. Eriksson, Chief Medical Officer at HMNC Brain Health, is a highly respected drug developer and clinical psychiatrist with over 20 years of pharmaceutical experience. Prior to HMNC Brain Health, Dr. Eriksson served as Chief Medical Officer at Compass Pathways and previously as Senior Director of Clinical Research at Lundbeck and Medical Science Director at AstraZeneca. Now, before we get to Dr. Eriksson, a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And a reminder, if you are a clinician and you would like to get more comfortable discussing psychedelic medicines with your patients, as more of these come online and become legally available, please check out the Psychedelic Medicine Association. It is our mission to get clinicians of all types educated enough on psychedelics so that you feel comfortable having those discussions when patients come in, start asking about whether psychedelics may be appropriate and effective for them. You can find us at psychedelicmedicineassociation.org. Now, without further ado, thanks so much for joining us, Dr. Eriksson.
Thank you so much for giving me the opportunity to talk to you. And I really like to be here. And I think I have a really interesting clinical story to tell you about how we are developing a ketamine formulation that seems to be largely devoid of the problems with other ketamine formulations. I just want to mention that I will mention some uses of ketamine here that are not FDA approved. So this is just for information.
I appreciate that. 90% of what we talk about on this podcast is not FDA approved, but it is in hopes that it will become. So we talk a lot about, different research that's going on and things that we hope to see FDA approved. So this is another one of those categories. Just a reminder, if people are going out right now looking for non-dissociative ketamine, it cannot be found anywhere. This is not one of those like find your underground non-dissociative ketamine dealer. This is something that is still in formulation. So thank you, Dr. Eriksson, for reminding everybody of that. We had another episode about a year or a year and a half ago on non-hallucinogenic psychedelics. So this is kind of similar because Dr. Eriksson will be talking about a non-dissociative because if you followed the podcast for all these years, you may know that ketamine is not a traditional psychedelic. It is more of a dissociative than a hallucinogenic. So Dr. Eriksson, before we get into all of that, can you tell us a little bit how you got involved with researching, because I know you were previously researching psychedelics and now ketamine.
I mean, I'm a clinical psychiatrist by training, but I've spent close to 25 years now in the pharmaceutical industry with late-phase drug development. And the main reason I decided to take the step from clinical practice into drug development is that I believe that there is more that can be done by developing novel treatment approaches. And over time, I have become convinced that some of the approaches that are, or have been, I should say, leading in the big pharma context are not really appropriate for the broad psychiatric disorders like depression. So just to give an example, there may be two patients with major depressive disorder that do not share a single symptom, even though they are actually properly diagnosed. So it really tells us so much about the variability in the depressive syndrome. And I think we need to find more specific methods and more efficient methods. So therefore I decided to go into the pharmaceutical industry. And in recent years, I've been working with psychedelic compounds and now with ketamine, because I think there is additional benefit to gain from these novel mechanisms of action compared to the traditional monoamines that we base all our standard antidepressants on.
Okay, that's a very interesting background. I love that what has driven you to do this research. Now, like I said, today we're discussing your specific focus currently on non-dissociative ketamine. Can you talk a little bit about the kind of ketamine that is currently available and what types of effects that it has been shown to have that you may be trying to replicate with this new version?
Yeah. I mean, ketamine is a fascinating story. I mean, it is an anesthetic originally developed in the US by Park Davis during the 60s. It has gained use since the early 70s. It's a safe anesthetic. It's used also outside of hospital settings, in emergency areas, in war zones, and has a really defined role within anesthesiology. And during the 90s, the group around John Crystal at Yale did some really groundbreaking research published just around the turn of the millennium, showing that subanesthetic doses of ketamine are actually associated with a very rapid and profound antidepressant efficacy, which was, I think it was a surprise to many. At that time, it was known that ketamine is an antagonist of the NMDA receptor. So it was generally believed that this is an NMDA-mediated mechanism of action. We'll come back to that later because the story may be more complex than so. But over the last little more than 2 decades, there has been an increasing interest in using ketamine and ketamine-based medications to overcome depression. So what happens when you treat someone with ketamine? Originally, it was done with intravenous administration, is that you typically get a very early onset of antidepressant efficacy. We're talking about hours to days. This antidepressant efficacy is typically accompanied by a series of other effects. There is an increase in heart rate, there is an increase in blood pressure, and many persons experience dissociative side effects, which can be described as sort of an out-of-body experience, which some people think is not really desirable, while other people find it a desirable effect. But a large proportion of individuals do not really want to experience that in the context of a depression treatment. But despite this, ketamine has gained increasing use, both in clinics that are using the intravenous form of ketamine, which is then technically off-label. It's not approved by the FDA for use in depression, but especially in the US, we have seen quite an extensive use of IV ketamine, intravenous ketamine. But also larger pharmaceutical companies have gone into the field. So the Janssen company, which is part of Johnson & Johnson, has developed an intranasal formulation of the S-enantiomer, which can be described as one of the 2 mirror image molecules of ketamine. So they have developed S-ketamine as a nasal spray for depression. And they've been able to show that it comes with rapid efficacy, substantial efficacy, based on a completely novel mechanism of action compared to the standard antidepressants, but they have not been able to get rid of the effects on blood pressure, heart rate, and all the dissociative experiences. But nevertheless, it has become an important treatment in the psychiatrist's armamentarium, and we see more and more interest in this space. So we can say we have a very efficacious treatment which has a profile of accompanying effects that are not only beneficial for the patient.
Yes, thank you for that comprehensive look at ketamine. And I like that you point out that some people do think that the dissociative effects are desirable and other people don't. And I think that, this is something that we try to remind people of, is that there is a wide range of patients out there who can benefit from things and a wide range of tolerances. And some of those, like for some people, a dissociation may be contraindicated based on what their medical history or a psychiatric history might be. And so I just want people to keep that in mind whenever we're talking about these kinds of medicines, is that there's, we want to make sure that there is a option for every patient out there. And so can you talk a little bit about, let's even just talk about, like you said, the heart and like the cardiovascular effects that regular ketamine may come with that a different form may not.
Yes. So soon after immediate administration of ketamine, whether it's an intravenous infusion or whether you take it as a nasal spray, you typically see an increase in heart rate and blood pressure. So it's a modest increase, perhaps some 10, 15 millimeters mercury in blood pressure, but it's clearly measurable. There is also, in many cases, some sedation, so people get slightly drowsy, and a relatively high proportion get these dissociative experiences. So it seems as if they are really associated with this rapid administration of ketamine that is the current way of giving this medication.
And talk a little bit, if you could, about why the formulation that you all are working on, you think like which part of ketamine has the antidepressant effects versus the dissociative effects?
Yeah, I mean, it has been a bit of a surprising journey. So we are working with an oral formulation of ketamine. So take it as a tablet. And in contrast to many other tablets, the medication is not released immediately into the circulation, but it's slowly taken up, and the highest concentration is achieved somewhere between 6 and 7 hours. So it's a very slow uptake. And the idea behind this has been to, first of all, make sure that the highest concentration of ketamine doesn't get that high, and also to make sure that this happens after several hours, so that there is a possibility for some sort of adaptation on the target organ level. So that was the idea when this development program was started, and we are aiming for a similar exposure to the drug as that you achieve with, for instance, an intravenous administration, but we are achieving a much lower peak concentration, the maximum concentration of the compound. So that is one of the characteristics of our formulation. And you could, of course, say that if you give a medicine which does not reach a really high concentration, maybe you're losing something on the efficacy side. And before we did the studies, my answer was, yes, we don't know. We need to find out. So we did the studies, and we have some pretty surprising results that have been really interesting also to the team. I think we have probably reached a bit further than we initially thought that we would do.
And which part, like, what can you tell us a little bit about what the studies found as far as what were you comparing your compound to placebo?
Yes.
Or to the regular ketamine?
Yes. So right now we have had readouts from two studies in patients. They're called phase 2 trials, so they are the first trials in patients. These patients all have something that is referred to as treatment-resistant depression, or TRD. And the definition of TRD is slightly variable, but in most cases it's about having been not responsive to at least 2 courses of a standard antidepressant treatment. So these are people who are depressed. They have been fighting with the depression. They have really tried to take the approved treatment, and they have not overcome their symptoms. So it's obviously also a huge unmet medical need. So at first there was a small study conducted by an academic group at the University of Zurich in Switzerland, led by Professor Eriksson. And they saw in a small study interesting positive signals of early efficacy of ketamine in our oral formulation. And that prompted us to design and run a large phase 2 clinical trial in Europe. So we conducted this study in patients with treatment-resistant depression. They got the medication as a tablet, 1 tablet per day, on top of the standard antidepressant, and they were treated for 3 weeks daily. So it's a relatively intensive treatment. And we explored 2 different doses of ketamine. So what we could see in this study was that the individuals that got the highest dose of ketamine that we used in our study, they had a rapid improvement in their depressive severities already after 7 hours. The decrease on a standard rating scale was about 2 points, which doesn't mean much unless you are familiar with the scale. But typically, a separation of 2 to 3 and sometimes 4 points is what is seen in positive clinical trials in depression. So that separation of 2 points was not statistically significant, but already after 4 days, the separation was statistically significant and also clinically relevant. And the improvement from baseline continued during 3 weeks on treatment and also during 4 weeks during follow-up. So it was a strong signal of initial efficacy, which was very reassuring to us. We did not hit statistical significance after 3 weeks when we had the primary efficacy endpoint, but at each assessment there was a numerical and clinically relevant separation from placebo in this study. So it gave us the confidence that our formulation indeed seems to have the properties that can bring down the depressive severity. So we were very happy with that. But that's only part of the story. There's another part as well, because we also need to look at the other effects of the compound. So, for instance, when we looked for effects on heart rate and blood pressure, we didn't find any separation from placebo at these doses. When we were looking for dissociation, we were using a scale, a rating scale that is called the CADS scale, that is, I would say, the gold standard to measure dissociation. And on that scale, we also didn't find any difference between active dose and placebo. So it seems as if this antidepressant benefit was delivered without the drawbacks that you can see on, for instance, blood pressure, and also we did not see this dissociative phenomena, which was in a way it was what we were aiming for, but I think the difference was compared to conventional treatments was larger than we had anticipated, and now we have an idea about why this is the case.
And can you talk a little bit about the metabolites versus ketamine as for what was having the dissociative versus the antidepressant effect?
Yes. So, as mentioned, ketamine is a strong antagonist, a blocker at the NMDA receptor. And then the NMDA receptor mediates signals by among others, the glutamate, which is an excitatory amino acid. And since this efficacy is so profound, people in the field have generally believed that, okay, the antidepressant efficacy must probably also be mediated through this NMDA receptor. So what we are seeing when we are giving our oral formulation is that it's very slowly released in the gut. It's taken up, and everything that is taken up from the gut is essentially going through the liver. And the liver has a protective function for our bodies. It protects against foreign substances, and it's trying to metabolize them. And ketamine is a foreign substance, like all medications, more or less. So the liver is metabolizing ketamine, but there's a slow delivery of ketamine to the liver, so it has the ability to profoundly metabolize ketamine. So the amount of the parent molecule, ketamine, that reaches the general circulation is very low. So the concentration is so low that it does not attain the levels that cause blood pressure increase or dissociation, which is, of course, very important on the tolerability side. And then, of course, if one were devil's advocate, one would say, okay, but then you don't have efficacy. But we think we have an understanding of the efficacy as well, because the ketamine that is metabolized ends up somewhere else, and we see relatively higher concentrations of metabolites like norketamine and hydroxynorketamine. And these compounds have been shown to possess antidepressant efficacy in animal models of depression. So we believe that we have been able to avoid some of the NMDA-mediated efficacy, but retain the antidepressant efficacy, which in our hypothesis is mediated through different mechanisms. And we do not think that the NMDA receptor is the key mediator of the antidepressant effect, but that there may be other signaling systems. For instance, the AMPA system could be involved. So to some extent, to our surprise, we've been able to disentangle efficacy from side effects that for many patients are unwanted.
Very interesting. Well, thank you for that explanation. I was wondering, as you were mentioning the daily use for 3 weeks, in regular, normal ketamine, dissociative ketamine, there is a history of bladder side effects with repeat use. Is
Yes.
that something that you were concerned about with your study?
I mean, yes. I think it's well known that repeated use, especially at high doses, also among people who regularly use very high doses, is associated with bladder effects. And the reason that we gave it daily in this first study was we wanted to find at what time you get optimal efficacy. And it seems as if we can achieve that after about a week. So going forward, our thinking is to use less frequent dosing, because we recognize that probably the overall dose that you receive has some relationship to the risk of getting these bladder effects. So the first step for us was to show there is efficacy, and the next step will be to evaluate how much can we decrease the dosing while maintaining efficacy. So that will be the next step. So I'm glad that you bring this up because that's an aspect of ketamine that is not always recognized.
Yeah, Phil, thank you for addressing that. And another aspect of ketamine that I think is coming up a lot more is the addictive potential. And I was wondering, excuse me, I was wondering if obviously we would just assume that if people are taking it for the dissociation effects, that they would not want to take a non-dissociative repeatedly. But is there any physiologic reason that the non-dissociative version may still have that addictive property?
It's an important question. I mean, I think for many persons who become addicted or use more ketamine than they should use, I think the dissociative experience is an important component because some people find it desirable, and that is what drives the use. I think with a compound that is, when administered the way it should be administered, is virtually devoid of dissociative experiences, should in itself be less prone to cause dissociation. But we need to remember that the compound is there, and there may be ways that some individuals will try to get higher exposure to ketamine. Fortunately, with our compound, if it is crushed in a mortar, it becomes a almost chewgum-like mass, which is very difficult, if not impossible, to snort or to inject. So there are some abuse deterrent properties built in, but we are really aware of these risks, and our plan is, of course, to work closely with the FDA in the future to look into the abuse liability of the compound. Our expectation is that it will be low, but we also need to be careful because it is a powerful medication.
Thank you for addressing that. And people may also be wondering, we've had the discussion with some other practitioners on the show before about there are already kind of two schools of thought or two ways of giving ketamine. One is we give a psychedelic dose where, the full hallucination. And then there's one where we often see them giving a psycholytic dose where it just does enough to kind of facilitate the therapist bond with the patient. Can you talk about how your
Yeah,
molecule is
sure.
different from that psycholytic lower
Yeah.
dose?
I mean, first of all, I think we need to be humble here and recognize that this is uncharted territory, and there may not be one single solution that is optimal for everyone. But I think that if you are giving a very low dose of ketamine, let's say intravenously, to avoid the dissociative and blood pressure increasing effects, I'm not sure that you will get high enough doses of high enough concentrations of the downstream metabolites. So I think you may be able to avoid some of the unwanted effects, but it may come at the cost of decreasing efficacy. So our view is that it's probably better to try to use the metabolism in the body as a tool to achieve very low exposure to ketamine, but high exposure to the downstream metabolites.
That makes sense. And I appreciate you saying that there's not one single solution for everyone, because it may be that, especially I know that there are a lot of psycholytic uses that are, say, an oral dose, low dose given, but like I said, more to facilitate the psychotherapy. So it may be
Yep.
less that they're looking for, like you said, those direct cellular antidepressant effects and more for like the therapeutic alliance. But if people are looking for more of the direct antidepressant effects, maybe something like your
Yep.
molecule would be the
Thank
more
you.
effective. I appreciate this very much because that is, like I said, one thing we always want to consider is having as many solutions for as many types of patients as possible. Now, that brings up the question, what have the thoughts been with your team about the role of psychotherapy with your medication? I heard you say that like the patients in the study stayed on their antidepressant, so there seems to be no interaction there. But is there thought to be that therapy is useful in that window where they're taking the medicine?
I mean, as a clinician, I can say that psychotherapy in general is something that is good to combine with other treatment approaches. So, I mean, there's nothing controversial in, for instance, combining standard antidepressant therapy with one of the modern psychotherapies, cognitive behavioral therapy, or interpersonal therapy, or what you go for. Um, And I think the same holds true for ketamine. However, I do not think that there is a strong need to provide the ketamine treatment in the context of a psychotherapy. So we have actually actively decided not to combine the biological treatment with the psychological treatment here. And that's not because we do not believe in the psychological treatment, but we want to explore the efficacy of the biological treatment as such. But it's also important to mention that in this day and time when we see lots of new compounds or repurposed compounds with really mind-altering properties coming into clinical development or clinical use, uh, all of them are not the same. There are different mechanisms of action being involved. I used in the past to work with psychedelics, and for psychedelics, I think that the psychological component is more important. Whether it's more about creating a safe setting where the medicine can be administered, or whether you also would like to exploit the psychedelic state for interventions. So there, I think it's different. But my belief for now, at least, but I'm ready to change my mind, is that it does not seem as if psychotherapy is necessary for good antidepressant efficacy of oral ketamine, and I don't think it's necessary for the other ketamine treatments as well. But of course, there is nothing wrong in adding a psychotherapeutic treatment together with a more biological approach.
Well, I was wondering if, I'd recently been looking at the critical learning window opening period that described that ketamine opens, after like a single dose, right, opens up like a 48-hour period where the critical learning, where the learning window is back open. I keep forgetting the exact way to say it, but like where your brain is more in a childlike state, really ready to absorb new information. Do you
Yep.
think that is pretty similar? And I guess it might be, if you're giving it for a number of days in a row, that period may stay open longer.
I mean, there are some indications that sort of a neuroplasticity window is being open where long-standing changes can be achieved in the biological system. It's very interesting and something that we would like to learn more about. But we have decided not to take that as the first step. First, we want to demonstrate that our oral ketamine formulation is safe and efficacious. But I'm quite convinced that either we or some other scientists down the road will explore the interaction between the biological intervention and more of psychological approaches. I mean, as long as it's in the interest of the patients, it's of course a good thing to do.
And just one thing to finish up with, because it's something you had mentioned to me before we started recording, because we like there's always this debate as to whether the trip or the hallucinatory component is necessary. And you had some comments about your previous work with psilocybin versus ketamine and your thoughts as to whether or not that portion, the kind of trip-like portion, is required.
Yep. And I mean, I think the jury is still out on this, but if I were to guess, I think that for the psychedelic treatments, I think the experience is important. I don't know how important it is, but I think it is sort of an integral part of the treatment. While it seems as if for at least the ketamine formulation we are exploring, it seems as if the lack of the experience, so to speak, does not really hamper the overall efficacy.
And when you're speaking about where you think in psychedelics, and just for anybody who is a little confused, he's making ketamine as a dissociative and something like psilocybin,
Yes.
LSD as in the psychedelic class. When you said you think that it's more likely that the trip may be necessary, are you speaking mostly for some things like depression, treatment-resistant depression, more on the mental health side?
I would say yes and no. I think I'm speaking to the depression side, but also, I mean, if you look at people who have been exposed to psychedelic agents, also if they have not been depressed, they typically refer to it as one of the most important experiences in their lives. It's not a single person or a single patient who comes with those comments. I think we see them time after time. And my guess, because I don't know yet, but my guess is that yes, it plays an important role, but it probably is not the entire story.
Got it. Well, I appreciate those thoughts. Can you tell people as we wrap up here where they can find out more about you and the research you're doing?
Yes. So I'm working with a company called HMNC Brain Health. So it's HMNC and hyphen and then brainhealth.com. We are based in Munich, Germany, and we are involved in actually 3 different development programs. The ketamine program is only one of our programs, and we are doing this as a collaboration with a Swiss pharmaceutical company called Develco that has developed the slow release formulation.
All right. Well, thank you so much for coming on and sharing and probably opening people to a whole new line of thinking about ketamine that they had not been open to before or not had maybe even considered before. So I really appreciate you coming on and sharing with us.
Thanks for having me. It was a nice discussion.
Absolutely. All right. For everybody else out there, until next time. Thanks so much for listening to the Psychedelic Medicine Podcast. If you enjoyed what you heard, please leave a rating or review as it helps others find the show. And if you'd like to learn more, you can find the show notes at plantmedicine.org/podcast, and there's information for clinicians at psychedelicmedicineassociation.org. Our incredible music was by the one and only Porangi. We'll see you next time.